I am Dr. Jason Johnson, one of the Pediatric Cardiology Fellows at Duke University. This is the voice annotated presentation on long QT syndrome with emphasis on this disease in the pediatric population. This presentation will go over how to measure the QT interval. I will discuss the incidence and characteristics of long QT syndrome. I will speak briefly about the genetics of the disease and then explain how the genetics of the disease can have a specific phenotype with specific clinical manifestations. I will end with discussion about the diagnosis and treatment options for these patients. I will start by defining the QT interval and review how to measure that on the electrocardiogram. Knowing how to correctly measure the QT interval is very important in diagnosing long QT syndrome. The QT interval varies with age, and there are established norms. Typically, lead 2 and lead 5 is the best for measuring the QT interval. A normal QT interval is less than 0.44 to 0.46 seconds. The QT is usually the longest in V2 and V3. To account for increased heart rates in children, the corrected QT interval, or the QTC, is calculated. The formula at the top right of the slide is a formula to calculate the corrected QT interval. The QT interval divided by the square root of the preceding RR interval is called the Bazet formula. It is very important to remember to keep the measurements in seconds and not milliseconds, or the equation will be wrong. Also, please become familiar with how to measure the QT interval. The image on the bottom right depicts the correct way to measure the QT interval. The QT interval is defined from the beginning of the Q wave to the end of the T wave. The incidence of long QT syndrome is 1 in 10,000 live births. This syndrome is caused by a genetic abnormality that causes delayed repolarization of the heart. This creates a prolonged action potential seen as a prolonged QT interval on the ECG. Long QT syndrome is caused by abnormalities in specific ion channels. The figure on the right of the slide shows an ECG from a single contraction with a QRS complex and a T wave. The initial depolarization of cardiac myocytes through gap junctions, or cell-to-cell connections, activates the inward sodium current that depolarizes the myocytes rapidly, which is the phase 0 of the depolarization seen at the bottom right of the slide. Transient outward potassium current during phase 1 creates a notch during the early phase of repolarization. Balance of the inward depolarizing calcium current and outward rectifier potassium currents, IKS and IKR, form a plateau phase, or phase 2. Deactivation of the inward current and increase of the outward current complete repolarization, phase 3, and the membrane potential returns to its resting potential, phase 4. It is important to know some of the ion channels as these are adversely affected in long QT syndrome. The genetics of long QT syndrome is complicated and occurs at different sites. There are multiple known mutations in over 8 gene loci. The most common types are listed here, with their associated gene defect. KCNQ1 leads to long QT type 1, and causes a loss of function in the IKS channel. KCNH2 leads to long QT type 2 and causes a loss of function in the IKR channel. SCN5A leads to long QT type 3 and causes a gain of function in the sodium channel. Types 1 through 3 account for 90% of long QT syndrome. However, you should remember Romano-Ward syndrome, which is an autosomal dominant form of long QT syndrome with variable penetrance. Also remember Jervell and Lang-Nielsen, as it is associated with sensory neural deafness with long QT syndrome. The clinical manifestations are not specific to long QT syndrome. The most common presentation is one of syncope brought on by exercise, fright, or a sudden startle. Patients can be seen with seizures, pre-syncope, or palpitations. However, it is important to realize that 10% initially present with cardiac arrest. The interesting aspect of the genetics of long QT syndrome is that the type can have a phenotypic appearance. The typical phenotypic presentation of cardiac arrest or syncope based upon the genetic subtypes are as follows. In patients with type 1, cardiac arrest or syncope typically presents with exercise, specifically swimming, and emotion is associated as well. Emotion, auditory startle, and somewhat exercise are associated with long QT type 2. For type 3, it is actually rest, sleep, and then less emotion that causes cardiac arrest or syncope. The diagnosis of long QT syndrome is mainly established with electrocardiogram criteria. Typically, if patients have a QTc greater than 480 milliseconds, they have long QT syndrome. However, one can't rely only on the ECG. In fact, 33% of mutation-positive patients, or patients with known genetic long QT syndrome, have a QTc less than 480 milliseconds. Therefore, the Schwartz criteria developed to diagnose long QT syndrome. It uses a point system to help diagnose long QT syndrome. Most of the points are related to ECG findings, but clinical history and family history play a role. Patients with more than 3 points have a high probability of having long QT syndrome. Therefore, a patient with a QTc greater than 480 milliseconds and an uncle with known long QT syndrome would have 4 points, 3 for the ECG findings and 1 for the family history. They would have a high probability of having long QT syndrome. This is a 12-lead electrocardiogram of a patient with type 2 long QT syndrome. His history is one of a 7-year-old boy who presented to the emergency department with a syncopal episode. The episode occurred when he was surprised by an unannounced visit from his grandparents. His corrected QT interval on this ECG is 550 milliseconds. He later had genetic testing to confirm a defect in the KCNH2 gene, leading to loss of function of the IKR ion channel, consistent with long QT type 2. Torsades de Pointes is a form of polymorphic ventricular tachycardia with characteristic beat-by-beat change, or twisting around the baseline, in the QRS complex, and occurs frequently in patients with long QT syndrome. Torsades de Pointes is literally translated twisting of the points. This can cause syncope and degenerate into ventricular fibrillation, resulting in sudden death. Torsades de Pointes is typically preceded by frequent premature ventricular complexes. The figure at the bottom of the slide depicts what happens in a patient with long QT syndrome type 2 who experiences an alarming auditory stimuli. There are multiple premature ventricular complexes that eventually lead to Torsades de Pointes at the end of the electrocardiogram. The treatment of long QT syndrome is somewhat limited. There is no definitive cure. Typically, one would start with lifestyle modifications based upon the type of long QT syndrome. There is no competitive sports participation allowed in all types. In patients with type 1 long QT syndrome, only supervised swimming is allowed. In patients with type 2 long QT syndrome, there are no alarm clocks or phones allowed in the patient's bedroom. Beta blockers have shown to decrease syncope and incidence of cardiac arrest. Beta blockers have not been found effective in patients with long QT syndrome type 3, and typically these patients are placed on mexiletine. If patients have previous cardiac arrest, an implantable cardioverter defibrillator is added to beta blocker therapy, and that would be the standard of care. I will end by reviewing the genetics, clinical features, therapy, and electrocardiogram of each of the different types of long QT syndrome. Long QT syndrome type 1 is caused by a gene abnormality of the KCNQ1 that causes a loss of function of the IKS channel. Type 1 is the most common type and is associated with syncope during exercise, specifically swimming. The sudden death rate is 0.3 per year, and the median age to first cardiac arrest is 9 years old. Beta blockers are very effective in this patient population. Long QT syndrome type 2 is caused by a gene abnormality of KCNH2 that causes a loss of function of the IKR channel. Type 2 is the second most common and is associated with syncope with auditory stimuli or emotions. The sudden death rate is 0.6 per year, and the median age to first arrest is 12 years old. Beta blockers are effective in this patient population. Long QT syndrome type 3 is caused by a gene abnormality of SCN5A that leads to a gain of function in the sodium channel. This type is uncommon with a low incidence of symptoms. Type 3 is associated with cardiac arrest during sleep. The sudden death rate is 0.6 per year, with the median age to first event at 16 years old. Mexiletine and beta blockers are minimally effective in preventing cardiac arrest, and these patients often get implantable cardiac defibrillators. The different types of long QT syndrome have characteristic types of ECGs. You would not be expected to know this. I put these different examples in this presentation to show you that all the types have a prolonged QT interval. These are references to 2 book chapters and great review article in The Lancet, where most of the figures originated. Thank you for your time.